Dr. David Black, Founding Director of the American Mindfulness Research Association, Associate Professor of Preventive Medicine at the University of Southern California, Keck School of Medicine, and Affiliate Faculty of the USC Norris Comprehensive Cancer Center. Today's interview initiates a new service for our association. I've been wanting to create this for over 2 years, and I've mostly been delayed due to being a new parent, and now finally getting the ball rolling with a son that's transitioning to preschool. And so I have time and energy once again to come back to extraneous things at work that I want to enjoy. And so this first interview focuses on mindfulness as applied to cancer survivors. And this is especially close to my heart. So sad news, my father passed away this last year. And he was battling with various health conditions, but one that was really taking away his quality of life was the recurrent prostate cancer. It was stripping away some basic dignity in daily life, and really his complaints were focused around that and his lowering quality of life before he finally passed through indirect complications. And then, so after kind of getting through that, and we're in the middle of this COVID era, and we still haven't done our ceremonies yet. More sad news has hit our family 3 weeks ago. This is my wife's father, just diagnosed with a rare sarcoma, and now he's battling with cancer as well as massive anxiety. He was already somewhat anxious before, and boy, this has really made it terribly worse. And so he's in the middle of treatment. So I'm seeing like end of life with cancer. I'm seeing new diagnosis with cancer. So this is really close to my personal experiences right now. And in this conversation that we have today, in an inaugural podcast of sorts, in an interview, I hope to explore the impact of mindfulness on the lives of cancer survivors. And I'm lucky today to have my guest, Dr. Linda Carlson. Dr. Carlson holds the Enbridge Research Chair in Psychosocial Oncology. She is full professor of psychosocial oncology in the Department of Oncology at the Cummings School of Medicine at the University of Calgary. She is the director of research and works as a clinical psychologist at the Department of Psychosocial Resources and the Tom Baker Cancer Center. She is the editor-in-chief of the journal Psychosocial Oncology, Research and Practice. She has co-authored a patient manual with a short title being Mindfulness-Based Cancer Recovery, as well as a professional training manual entitled The Art and Science of Mindfulness, Integrating Mindfulness into Psychology and the Helping Professions. She has over 200 research papers and book chapters published, and she's currently president-elect of the Society for Integrative Oncology. So she has done tons, and I haven't mentioned it all, and I want to welcome you, Dr. Carlson, today.
Thanks, David. It makes me sound really impressive when you read all that out, but I'm really no different than anyone else.
And you indeed are. Thank you so much for joining me.
Yeah, and I just wanted to comment too. I'm very sorry to hear about your father's passing over the last year. It's a terribly difficult time for all family members, and even more so, as you said, in this COVID era. And you already pointed out a couple of important things around coping with cancer, which is the balance between quantity of life and quality of life, right? For most people, many people anyway, value quality of life. So living better rather than living a little longer, right? Because dragging things out when you have a poor quality of life and you've lost your dignity, a lot of people don't want to live that way. And so our focus in psychosocial oncology is, helping people live well. And that's our kind of logo, or our motto is living well with cancer. And the same thing, your issue with your father-in-law and his anxiety. We know that people who have a history of mental health conditions are going to struggle more with cancer. And we also know that being isolated during the pandemic makes all that worse. So, so many things already in what you said that are relevant.
Yeah, thank you so much for that. And your accounts are definitely things that I've been experiencing recently. And so to open for our audience, I've given you an introduction, and it was overly formal, but they probably want to hear a general account about you and your work, as you do know a lot about cancer survivors. And so maybe just more generally, the type of research you do in your day-to-day life and the type of practice you have with cancer survivors?
Yeah. So I have been working with cancer survivors since the very end of my PhD, which was, I'm dating myself here now, but back in 1997. So prior to that, I was doing a PhD in clinical psychology. I trained at McGill University in the area of behavioral medicine, or more technically, it was psychoneuroendocrinology. And that really is just a fancy term for the mind-body connection. So I've always been interested in how our moods, our thoughts influence what's happening within the periphery, within our body systems, our nervous system, our immune system, our hormones. All these things are interconnected. And so that's always been my interest. And then when I came back to Calgary, which is where I'm originally from, and began working as part of my residency, before you finish your PhD, you got to do a year of clinical work. And I just ended up at the Cancer Center as one of my rotations. And really, I found a home there, I guess I would have to say, with the people I was working with and the interest they had in these mind-body therapies. And so that's where I began developing a mindfulness-based intervention program for cancer patients, along with some colleagues, Michael Specka, chiefly among them, who were interested in the same thing. So that's where it all began back in 1997. We did our first study in 1998. Since that time, we've explored many aspects of mindfulness within people coping with cancer, as well as family members, and also expanded that to other integrative medicine modalities. So I've done studies on, most recently, we've looked at acupuncture, but over the years, I've done lots of work with yoga. We've looked at Reiki, we've looked at animal-assisted therapy, light therapy, a whole range of different things, all adapted or designed to help people cope with this myriad of problems that arise when you're diagnosed with cancer.
So you mentioned that part of your love for this field was finding a good team to address solid problems. And it seems like you've used tested a lot of methodologies. You mentioned Tai Chi, yoga, and others. This seems to be in a realm of holistic care. And did you demark any part of history when you really saw this happening, the transition, say, from just going to the clinic, getting your treatment and going home, to when centers were focusing more on a holistic care approach?
Well, our center has always been a leader in psychosocial oncology in Canada and around the world. And that's largely due to the work of my department head, Barry Baltz, who's very well known. He was the president of the International Psycho-Oncology Society, et cetera, et cetera. And so through his efforts, we've always had a large team of psychologists, social workers, psychiatrists dedicated to the whole person approach to dealing with people who are living with cancer. So we've always had a biopsychosocial, we've always looked at both the spiritual side, the social side, the emotional side, as well as the physical side. So bringing in the more what we would call complementary approaches, where we're looking at these kind of therapies that are less evidence-based at the time or less proven, was not that much of a stretch for us. And I really encountered very little resistance at all. Although I hear other people saying, they had quite a bit of difficulty studying or bringing meditation or mindfulness into their programs. Really, I didn't encounter any of that. And in fact, a funny fact is that the head of the Cancer Center, who was just retiring when I started, was a yoga practitioner, and he meditated. So, he was all on for this, all on board. And so that's part of the reason I stayed there. And part of the reason I've never left is because it's always been a very supportive environment and quite open to these approaches.
Yeah, so it sounds like you were ahead of the curve with your group, and it's so important. So the holistic care idea became so pertinent to me just in this last week when I was mentioning my father-in-law and his anxieties because, they want all these CT scans.
Yeah.
And he got
where you're going. Yeah.
He just left. So if you just gave it, he would refuse to do it. It was so it created so much terror, they just left. So we had to connect with another friend who said, okay, bring him here. We will address the anxieties. We have to understand that this is a person, not just an object going in the machine. And now he has consented to say, okay, I will go back because all of us were terrified.
Just a second. Sorry, I'm recording a podcast right now. Okay, sorry.
It's okay. We can't hear it. At least I couldn't hear it. So I see this. So important that this person and all of their needs are attended to, or else, the treatment itself can fail for reasons we wouldn't think should be the proximal reasons, right? Just
yeah, but I mean, for him, that anxiety is a very real thing. They're trying to get you in this scanner. It's terrifying. Or people who have needle phobias, they have to get a bazillion needles and blood tests and chemotherapy infusions, and radiation therapy is also quite terrifying. So even just the practical element of helping a person get through their treatment, the psychosocial support becomes very important.
And so that term, psychosocial oncology, can you define that for folks that may be wondering what that encompasses and
Sure.
how your group has applied it?
And people don't like that name because it implies, someone's kind of psycho or whatever, or that, they're having problems that they shouldn't. So often it's referred to more as an element of supportive care, right? But really what the term psychosocial is getting at is that just a recognition of the psychological elements, and that's more the sort of interpersonal struggles people have with anxiety, distress, feeling depressed and sad, all the kind of existential fears of death and dying that cancer evokes for people. So that's sort of the psychological or the emotional piece. And then there's all the social piece too, right? So the interactions with family members, helping support family members, also practical things like, I have to take time off work. How am I going to pay the bills? How am I going to get to the treatment center? So how am I going to pay the parking? So these kind of things, the sort of more social practical elements are also part of that psychosocial oncology. And I guess I should also say that it goes, we talk about the cancer trajectory. So sort of the time of pre-diagnosis, the sort of period of diagnosis, and then the active treatment. And then there's often a follow-up period or a survivorship period, which can be extended, or perhaps a person gets a recurrence and they're more at end of life or palliative care. And so there's certain psychosocial issues that are more prominent at different phases of that trajectory as well.
So those are really important. So all the targets you were mentioning, such as the psychological effects of diagnosis, the social barriers, such as cost and other things in transportation, and then what interventions are classic for what you have either studied or seen at leading centers? So what do people need?
Yeah, for sure. And, standard supportive care is more what you would think of, around counseling psychology, or, just sort of having someone to talk to, a professional who has experience with this and can kind of reassure you that how you're feeling is normal, and give you some, tips around coping, and also just give you a safe place to talk about these feelings. And I mean, that's an important point too, is that often people, when they're diagnosed with cancer, feel very alone in the journey. They feel very isolated, that all these people around them, they care, but they don't really understand what it feels like to be the one who has the diagnosis. So having a place to go, people to talk to who do understand, often that's why support groups are useful, because you're with other people who are going through a similar thing. So those kind of approaches are very sort of standard psychosocial care. And I would say, I was going to talk about the kind of more complementary approaches, but I'll let you ask your question.
Oh, I was just going to, I don't want to interrupt. Just the social support, so people know kind of what we would say the standard of psychosocial care is. And I think one of the gold standards that we recognize in the field, correct me if that's not true, is the social support element of people going through a similar experience and being able to talk about it.
Yeah, so either professionally led or peer-led support groups. I often actually use this as an example of the difference between complementary medicine and mainstream medicine, because 40, 50 years ago, the idea of getting a bunch of people with cancer all together in one room and talking about it, professionals thought that was a terrible idea. How could that do anybody any good? It's just going to scare them all and get them down and depressed, right? How could that be useful? But people with cancer said, no, we want to talk to each other. And these sort of support groups got started. And then we began to realize the benefits. And there's hundreds of studies now that show a wide range of benefit. Just getting people together in an open, supportive environment where they can just talk about the hard stuff, the stuff that they're afraid to talk to their family about, because their family is going to get upset, or they're going to worry people. They don't want to, a lot of times it's the person with cancer who feels like they're taking care of everybody else because they're all falling apart. Right? So they need a safe place with a professional or with a group of other patients where they can just talk about all that stuff that's on their mind.
Yeah, and it seems like somewhat of a complex dynamic that would lead certain people to seek out support groups, but not others. So
And that's a
I
part of
think,
the problem. Yeah.
yeah. So if I think about my father, male may
Mm-hmm.
already be one of the barriers, fear of what others may think in a group, and there may be other characteristics. From research, do we know about characteristics of people that makes them more or less likely to enter something like a group format?
Yeah, for sure we do. And it's unfortunate actually, because lots of people who could really benefit are, steering away from those things. And you hit the nail on the head for one. It's definitely more women who come to support groups. It tends to be, people who can take the time out of their lives. So they're more highly, like higher income or highly educated. They tend to be white people, so it's a very select demographic in a lot of the studies in the support groups. And we've recognized that as a field and have really, some people more than others made great effort to diversify the availability of supports for different groups of people. Like, for example, for men, they don't want to come to a support group, right? And they're all, they're not going to put their heart on their sleeve, but they might come to an educational session, right? They might come to something where they're going to learn a skill. So you can brand things and name things in a way that appeals more to people who are information seeking versus support seeking. But then they can also get the support once they're there, right? They're in the environment, they come for the lecture, and then there's the little discussion group afterwards. And then they're like, oh, that was awesome to talk to other guys with prostate cancer, So
Yeah,
you can kind of, yeah.
The informal social dynamics that happen are still a support group.
Absolutely they are. Yeah, you see these guys, they'll come for a lecture on PSA testing, right? And then they can talk afterwards a little bit about their cancer experience, and, you can barely get them out of the room, right?
Great. Well, yeah, and that gives us insight about how we can convey these messages to our own family members and to the public when we're offering programs and conducting research. So those are really good points.
Yeah, and the issue of other diversity too, socioeconomic diversity, racial diversity, that's a problem that we've been working on for a long time. And one of the significant advances in the area is mandating a program of screening for distress as new patients come in. All new patients that come into cancer centers, there's actually now a mandate through the American College of Surgeons for a cancer program to be accredited. They have to screen new cancer patients for things like distress, anxiety, anger, and symptoms like fatigue, pain, practical problems. And they have to have in place a triage program so that people who score high on any of these problems, they get immediately addressed. And that's just as a matter of course, right? So then you're not relying on the patients to come to you, you're coming to them. And so the people who really need the support are more likely to get it that way.
Yeah, and underlying what you're saying is an institutional level signal that psychosocial oncology is alive and well, right? Because to take those assessments tells us that mainstream medical care is considering all of the person now. And I don't know if this is across the board for every institute. I don't know where that designation spans to. Do you have?
It's meant to be we did a survey, published a paper a couple of years ago, surveying 55 cancer centers across the states to see how well they were implementing the screening for distress sort of protocols. And they're doing pretty well, right? 80% say they're getting of everybody. So not everybody, but a huge chunk of people that were missed before are now getting screened and sent to appropriate services for whatever problems are identified.
Excellent. And so we were mentioning earlier about the different experiences that people face. So when you're diagnosed, I'm seeing that with my father-in-law, when you're treated and in remission. So we're heading this conversation in towards how to treat people well in a medical setting. What should we be aware of, like at the diagnosis stage, at the treatment? Are there true differences here in the experiences that people are facing, or is it so common that anxiety, anger, and other things are occurring? We can always give the same intervention, or do we need different ones?
Yeah, there's definitely nuance, right? So right around the time of diagnosis, not surprisingly, almost everybody has elevated anxiety and often depression, but anxiety is the most common response. And if you ask people, how did you feel when you heard those three words, you have cancer? For a lot of people, it's just shock, right? They can't even think beyond that. They don't hear anything else that's been said. They're confused, right? All the images and thoughts about what this means to them, all the memories they have, all the past experiences, often bad. flood their mind. So people are quite anxious at the beginning. And then often they're very quickly thrown into the doing mode, right? So, okay, we're going to start your treatment. You got your surgery, then you're going to have your chemo, your radiation, go, 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 right? And so they're so focused on getting through the treatment, getting the information they need. It's often not until post-treatment, which for a lot of people is about 6 months, sort of a rule of thumb. If you're getting your surgery and kind of standard chemo, for many people, it takes about 6 months. And so they get through all that, and all of a sudden they take a deep breath and go, oh my God, what just happened? They're like, what just happened to me? That's overwhelming, right? And then they feel this flood of emotions. And often that's a time when they come to us saying, okay, everybody says I'm fine now. I'm supposed to go back to work and carry on with my life. And, they're discharging me from the cancer center, and I am not in any way feeling ready for any of that, right? I'm questioning my life. I'm feeling lost. I'm struggling with difficulty sleeping. I've got this profound fatigue from the treatments, right? So that's a point in time where people often need a lot of support.
And then so did you mention the remission phase? And so properly treated, they say they got the help, they went to the support groups, they're feeling stable again, they're returning to family work Roles. What's going on with people for those years?
Well, cancer never goes away, right? So, I mean, there's a couple of things. One is that fear of recurrence. So there is always in the back of a person's mind, once they've had cancer and been treated, is it coming back? When's it coming back? Is that ache in my knee a sign that it's coming back, right? Is every little bodily symptom, does that mean the cancer's coming back? So it's never far from their mind, right? And it can be quite debilitating in many ways, just living with that constant fear. So the fear is one thing. And the other thing is what we call long-term or late effects. So some things don't actually raise their ugly head, as it were, until after treatment is finished. So for example, like lymphedema, which is swelling in the arm or leg, it's caused by the removal of lymph nodes, which is often done in the course of cancer surgery, can be very painful and long-lasting and dramatically impair a person's quality of life. Fatigue is the other huge one. So most people experience fatigue during active treatment, but for some people, it can be up to 20 or 30%. It just doesn't resolve. And this is not, I'm tired, I need to go to bed and I'll feel better in the morning. This is profound fatigue that is not relieved by rest or sleep, and leaves people incapable of resuming their former roles, whether it's, as a parent or going back to work. So there's many other sort of risks too that, like, for example, long-term cardiotoxicity. So some of the cancer therapies can damage the heart muscle, and then it makes you higher risk for other diseases, cardiovascular diseases. And for some people, for many people actually, there's continued therapy they have to take. For example, breast cancer survivors, a good chunk of them have to take anti-estrogen medications like pills, like every day for up to 10 years. And these can have negative side effects too. For example, joint pain, menopausal symptoms like hot flashes, inability to sleep. So there's lots going on even after that active treatment phase.
And during that phase, it seems like there's a subgroup, just to summarize what you said, that is going to continue encountering symptoms, right, in daily life. So fatigue, I think, is a classic one, right? We know high rates of fatigue post-treatment. Is it treatable, and how does psychosocial oncology group go about treating that? And are people looking for treatment? Do they just say, this is the new me and I'm going to just bear down, or do they?
Well, they used to, because their primary healthcare team would say, oh, there's nothing you can do about that fatigue. Just rest. It should go away, right? And so it was poo-pooed a lot in the past, but now it's actually recognized as something that's a pretty major barrier to a person's recovery. And the unfortunate thing, fortunate or unfortunate, is that there's no good pharmacological treatments for things like fatigue or even pain, or like some of the other side effects. There's this condition called chemotherapy-induced peripheral neuropathy, which is pain, tingling, and numbness in the fingers and toes. I know a guy who he couldn't even walk because his feet were numb, right? So this can also linger and be impairing, but there's no drug that treats it. There's no drug that really treats fatigue. There's, there are drugs for pain, but they have their own side effects and many people don't want to take them. So that's where these non-pharmacological approaches come in. And the best approaches, the best evidence-based approaches for example, for fatigue is exercise, as well as different mind-body therapies and nutrition, in fact.
And so with individuals, and we just cross the board with diagnosis, early treatment, and others.
Well, and we can also talk about palliative care or disease recurrence.
But yeah, let's touch on all the bases. Yeah. You want to say something there?
Well, I mean, just that these different kinds of approaches are amenable to help people throughout the cancer journey in different ways. So we're going to talk about mindfulness, right? And so mindfulness training and some of the relaxation, for example, can help at the very beginning with anxiety in a scanner, like your father-in-law. Right? These approaches can just help, decrease arousal in the nervous system and help them get through some of those day-to-day things. But the same approaches at the end of life can be used in a very different way, to help people look at, again, meaning and purpose, existential issues, what they think about the afterlife. Like the same kind of approaches can be tailored to the issues that are salient at different points in the journey.
And to cover all the experiences, there's a phenomenon where some people post-cancer treatment, especially with success, have new life realizations. And I don't want to overstate this because it has been overstated that, oh, look, cancer is a positive experience. Not saying it in that light, but saying it that some situations in life do reveal to us perhaps new directions and new realizations. Have you seen that happen?
Oh, absolutely. We call it post-traumatic growth, in the research world, or benefit finding. And it's this idea that any traumatic experience can be a catalyst for change because it makes us, again, stop, right? And I guess I haven't really talked so much about the core features of cancer, which is like loss of a sense of control over how one's life is going to sort of carry on, and also a lot of uncertainty and unpredictability. So those features, that realization that we don't have as much control as we thought we did, plus not knowing how your life's going to pan out now because all the plans you had, your retirement, your grandkids, whatever, are called into question with this cancer diagnosis. So it's actually a really good opportunity. And again, I don't want to say cancer is a good thing, but it's an opportunity to take a step back and ask yourself, well, wait a minute. Okay, I'm cruising here through life, maybe not thinking too much about what I'm doing or why. And here's a chance to ask myself, well, what is important to me? What do I value? Right? What brings me joy? Where is my meaning and purpose in life? And we know that people who have a sense of purpose or meaning, whatever it is, if they have that strong sense, they fare better through illness and they fare better psychologically in general, right? So this idea of using cancer as an opportunity to explore all these questions can lead to this idea of personal spiritual growth, right? Where a person, for example, we talk about also the concept of spirituality, which is not religiosity like going to church, but more about feeling a sense of connection with something larger than yourself, with other people, and again, ties into this idea of having purpose in life. So those questions often arise for our patients. And again, the mindfulness kind of container is a really great place to explore that.
Yeah, these traumatic events, when taken from that perspective, seem to make sense, right? Like we've evolved a really directive reward system to see things in the environment that we want to have, be motivated for those things. And then something comes along and basically says, we're stripping away that the world is an unknown and unpredictable place. And you have to like reconfigure your model, right? And it seems to like shorten the span of how far away that target is. It's like, wait, maybe that target needs to be here by tomorrow.
Yeah,
See, for some, it could help. It's like, I need to get to that target. I've been kind of just meandering, thinking that the target will find me at some point.
Yeah.
Is that ring true at all?
Oh, absolutely. And that's partly why I like working with these people, right? Because they are highly motivated. I've done lots of mindfulness programs in the general population as well. And they're kind of curious, or, if people are having unpleasant symptoms, maybe they're a bit more motivated, but nothing like the cancer patients I work with. Like they are truly seeking, full, heartfelt change, like real change in their lives. They recognize that what they were doing in many ways wasn't working for them, and they are very open to trying new things. And so it's very, it's a very gratifying group to work with.
Yeah, so that begs my question. So how is mindfulness practice important in the lives then of people with cancer in particular? Is it just
Yeah.
another thing? I mean, could they do anything? Could they just exercise? Or is this particular and beneficial for certain types of people?
So empirically, we actually don't know the answer to that question, right? That's one of the research dilemmas, is that there's been a ton of research looking at different mind-body therapies, including exercise, but we say, oh, I don't know, yoga or hypnosis or relaxation or mindfulness. All these things are better than nothing. We know that unequivocally. Any of those things you choose to do are going to help you feel better and cope better than if you didn't do them. But putting them head on, that's rarely been done in an empirical way, right? So is mindfulness better than yoga? Well, I don't know. It's never been tested. So that's from a research perspective. Now, from a clinical perspective, what I know from leading groups for, again, 22 years now, is that the mindfulness approach is very flexible for addressing the core concerns that patients often experience across a range of different things. So I guess that's partly why I like it, because it's adaptable and it really does cover a lot of the bases, right? Whereas some of the other mind-body therapies I think are a bit more specific, for maybe like Tai Chi Qigong helps more in the physical realm, for balance and strength, for example. The yoga people would say, yoga and mindfulness are very similar. But again, my clinical experience is much more in the mindfulness realm. And so what I see is that core existential and, kind of day-to-day dilemmas of people dealing with cancer is that loss of control, right? The realization, so for some people, for the first time in their lives, that there's not much they can do about, how things unfold around them in many circumstances. And B, they're actually going to die at some point, and it might be sooner rather than later, right? So this, we all know we're going to die. There's one way in, one way out, right? But it's all very theoretical. It's like, oh yeah, I could get run over by a bus next week, but you don't really think that's going to happen, So it's all something way off in the future. I'll think about that, when I'm really old and I'm close to dying. Well, no matter how good the prognosis, you hear you have cancer, you think, oh my God, I'm going to die, right? Or a lot of people do, or I might die. That's one of the initial reactions. So it's like, oh my God, if I die, what does that mean? Like, what does that mean for my life? What does it mean for my family? What is, what have I left behind me, right? So it can make people really stop and think, as I said before, and this idea of loss of control. And so the mindfulness approach that stems from Buddhist philosophy, of course, right, is so well tailored. That's the whole point of it, really, is accepting, that we can't create the world in our own vision, right? The first noble truth, there's suffering. The second noble truth, the cause of suffering is grasping, is trying to control things.
Yeah, that sense, I see the perfect harmony there of losing control and a training program that helps you accept the fact that you were never in control in the first place. And we can get deeper in that, but just so our listeners know which program we're talking about specifically,
Sure.
The Derivatives is the mindfulness-based stress reduction program. This is a program developed over the decade of the 1970s by Jon Kabat-Zinn, and then he ultimately ended up testing that with the pain team at University of Massachusetts, part of their medical center, and they had a pain clinic, and that was the 1980s where they first started testing this program. And for those interested, you can read the book Full Catastrophe Living, which details that program. Now, it includes meditation. It includes very light yoga postures with the intent to focus on the attentional and emotional elements as you're doing those very light postures, which probably would make it different from some of the things you do, Linda, which may be more intensive.
Oh, no, we do that.
Oh, you do the similar program. Okay, but just to know, there is more yoga proper where you're doing more intense pose and the development of physical capacities alongside that, which I'm not sure if that usually is the case with MBSR.
Well, so I can tell you.
There's a program we're talking about. Do you want to talk about that program specifically anymore?
Sure.
Because you've used that program, and maybe we'll talk about
I'll tell you.
Your use and then how you adapted it.
Yeah, absolutely. So, you talked about Jon Kabat-Zinn. Of course, his name has to come in the conversation because that's part of my path as well. So back in 1995, I was a grad student at McGill. And my other grad student classmate, who you would probably know, is Kirk Brown. You'd recognize his name because he went on to develop the Mindful Attention Awareness Scale. And so he was a classmate of mine at McGill, and we in fact had a meditation group that was meeting weekly. And so he was, ahead of me, I would say, in terms of his reading around mindfulness. And he knew of Jon Kabat-Zinn and invited him to come give a talk in 1995 at McGill. And so, of course, he invited me along, and I was like, who is this Jon Kabat-Zinn guy? Whatever. Okay, I'll go. And it was held in the university chapel. And I like to joke, it's the first time I ate a raisin mindfully, right? And it was, and I was taken. And so I read his book and really had been developing personal meditation practice and personal yoga, separate from my studies. And so when I came to Calgary and saw this interest in mindfulness, I said, hey guys, there's this guy called Jon Kabat-Zinn, read this book. And they were like, oh, this is perfect. We're going to develop our own program based on this model, and trying to be more specific to some of these psychosocial needs we see in our cancer patients. And so that's what we did. And actually, in the end, our program is more like MBCT, mindfulness-based cognitive therapy, which hadn't yet come out, or I think the book came out in 95, maybe. We were just sort of learning about it. And that model focuses more on the cognition side, the stories we tell ourselves, and how that impacts our interpretation of the world. So we included cognitive elements, but we kept the yoga from MBSR, the mindful movement. And I think that's a really important part of the program for our cancer survivors and patients too. I can get into that as an aside. So our program is a little bit of a hybrid of MBSR and MBCT. We shortened the sessions a bit. We streamlined the format. But in terms of content and approach, it's very MBSR, right? The key is different ways to understand and train yourself in mindfulness, right? We use the body scan. We use sitting meditation, awareness of breath. We do loving kindness practice, actually more and more focus on self-compassion and kindness over the years. We do walking meditation, we do some visualization and imagery kind of things, but really in spirit, it's the MBSR kind of approach.
And thank you. And your raisin note being, for the listeners who haven't done that activity, it's like one of the foundational and beginning elements of a mindfulness training course, because you're really trying to teach people how to engage your sensory experience and to be in touch with that sensory experience. And many people are like, wow, I've never eaten a raisin or chocolate in this type of way because I'm fully present and engaged. And that begins the journey of these practices.
And I've done it hundreds of times since then, leading groups.
Probably not the same as that first time though, right?
Well, every time is unique, yeah.
So the translation for and adaptation for cancer survivors, usually when we refer to the term adaptation for a program, a lot of it has to do with the language that we're using, because there are different needs across clinical populations. And so, of course, if there was a discussion of pain in one program, you may not focus on that so much because you're talking about the complexities and challenges of living with cancer.
Well, we do pain. Yeah. Sorry, finish your question.
Oh, so the question being, were there the adaptation specific to cancer? What does that kind of group look like when you're working with folks? Is there a language specific to cancer and its survivorship?
Well, so the way we work it is that we weave the issues that people bring up throughout the program, right? So, for example, you mentioned pain. It's not a standard part that we do a pain kind of meditation or awareness of pain. But if we have the check-in at the beginning, where we discuss homework practice before there's a didactic about, responding to stress or whatever it is. And so that's where the real meat of it comes up, specific to what people are dealing with, right? So if someone's like, oh, I couldn't sleep because I had pain. All right, we launch into the pain focus, right? Where we talk about how, the totality of suffering from pain is a product of the physical sensation of pain multiplied by the resistance, so psychological and physical resistance to pain, right? And so we'll go through that whole model on the spot if someone needs it, right? And then maybe give them additional home practices they can do that are specific to coping with the pain. And so it's like that. We have sleep exercise that's part of the program, because everybody has problems with sleep in this population, pretty much. And if they need more with sleep, we also have a cognitive behavior therapy for insomnia group that they can go to, right? So we touch on a lot of the common things, and then the issues that arise during the discussion, that's when we kind of address them.
Are there specific, from all your years of experience and seeing the groups and working with folks on a clinical level, are there any specific case studies that come to mind? Of course, keeping all information private, but just would kind of embody what we're talking about here, to see the transition, someone coming in, they're motivated, they want change, they didn't know exactly what it was. Are there moments when you really see them come to realization how important this is, or it was always there and they just didn't know it? Because I hear in MBSR, this often happens like session 4. People are like, oh my goodness, I didn't realize how important this was to my life, because it's all about me being present for what's happening.
Yeah, it happens every time. Like when you ask for a specific case. So I finished a group yesterday. And one lady, so at the last class, I do a guided meditation. I say, think back to the first class, how you were feeling. And I asked you to share, why you were here, what you're hoping for. And now reflect it today, like where are you at now? Did you go off in some other direction, or, is it still a work in progress? And so one lady came on and she said, I was really skeptical about this. I only signed up because I don't know why, someone had recommended it to her. She's like, I wasn't really sure what to expect. She's like, and now it's amazing. She's like, I get it. It's part of my regular routine. I'm going to continue with this. She had certain plans, so that was just sort of one example of, I hear it every single class. Another couple I had yesterday were like wellness people. Like they had run kind of a wellness program of some sort, that was around natural health products or something like that. And she said, I've always known this. She was the patient and he was the supporter, the husband. She said, I've always known about these things. I told people to do them. She's like, but I never really did them. I never really did these practices myself. And she's like, so this was a great motivation to actually make me do it. And she's like, and now I've, kind of renewed, understanding and vigor and enthusiasm for helping other people work through it. Yeah.
And so the dynamics, so folks know if they've been taking these courses, usually in MBSR in your class, it could be a weekly program where people meet up in person, or more commonly now online, and have to also do homework. Do you want to talk about the expectations for what you hope people would do to really get familiar with what you're asking them, and then what we ask them to do as they transition away from the program in their personal life?
Yeah. So I was just thinking of more people that keep popping into my mind. There was one lady last time who was an artist, and she did watercolor. She was a floral artist. And so she made a drawing especially for the group that, again, it was a Zoom group. So she shared it with me online, and I made a card for them from her. And it was so special for everyone to sort of get that. And actually with more recent groups, like at the last session, I leave and I let them stay and chat, just some kind of adaptations for Zoom, right? Because normally, we meet once a week. It's for 9 weeks now. And, they'll chat before the group. Some of them will go for coffee after. And on the Zoom environment, that's just missing, so it's been important to try and the other thing I do is put them in breakout rooms at the beginning for the review of home practice with like 2 or 3 people, and then bring them together to facilitate that. And another thing many of them say is, it's been so nice to be with other people who have cancer. And we've always had mixed types of cancers in our group. So it's not just breast cancer or whatever. It's all different kinds, all different stages. And that's really good, because it stops people from talking so much about their cancer, the specifics of it. Oh, I had radiation. Did you have that, oncologist? It's much more the sort of general psychological experience, right? So that's been really good. Now, your actual question was about home practice. And so I always took a lesson from Jon Kabat-Zinn, who had recommended 45 minutes of practice daily. And we had broken that down always into 15 minutes of the yoga, the mindful movement, and 30-minute meditation, whether it's a body scan or sitting or whatever. So that's what we have always recommended through the years. And I've had people say, oh, that's too much. How can you ask those cancer patients to do it? And, my response has always been, well, I ask them and they do it. No one's complaining too much. But we just did a systematic review on adherence to home practice in mindfulness programs in cancer specifically. So my team did that and pulled out all the papers who had covered that, and found that the average adherence was 60% of the assigned home practice that people were actually doing, which was an average 27 minutes a day, which is okay by me.
27 minutes a day on average to get people to develop a new skill. It sounds really good to me too. We can compare it to maybe exercise interventions. I don't know what their final minutes are, but I mean, those things after 6 months probably taper off almost to zero. So
and the other thing we always address in leading up to the last sessions is what's your plan going forward, right? You need a plan. Because we know that if there's nothing concrete in place, people will find it difficult to continue with the hard-won daily practice that they've most all of them have managed to establish. And so we've always had a drop-in group for graduates, a weekly drop-in. And we started that back in 1998. And literally last year on Zoom, I had to take those over for a while. And some of the same people were coming for like 20 years to the drop-in group.
Wow, that is amazing.
Unbelievable. Yeah. I mean, it's a good story. One of the women who's the most hardcore, she's a writer and wrote us this beautiful poem that we use in our program now about, it's called the tea ceremony. Beautiful poem. So they have that as an option now. So they're all invited to join that. And we give them all kinds of resources locally for different groups and programs they can join and task them all to create a plan and share it.
And so it seems from this last part that we're talking about, there is a group dynamic. So we can't deny that the group itself is probably having an impact on wellness states, having a connection to other people in a similar experience. And then the mindfulness element itself is doing something hopefully independently, or we could do anything. So maybe let's go through some essential activities. So you keep mentioning the body scan. Can you just generally talk about how that happens and why we would do it at the start of a program?
Sure. I mean, and again, we're taking a lesson from Jon Kabat-Zinn there, but there are good reasons why we start with the body scan with this population. First of all, if people don't know, the body scan is a guided meditation where you can start at the toes or start at the head, but you very slowly move through each body part, just sensing without judgment, kind of what your experience is, what thoughts arise, if there's tension or any kind of sensation, and very slowly moving through the body over the course of usually about a half an hour. And so that is training attention, which is really the initial focus of a mindfulness program. And the way we present it to people is that you're learning a new skill, right? Or you're learning a new skill of paying attention in the moment. Your mind is not trained to do that, right? Your mind likes to jump around to the past and future. And so just like playing the piano or learning tennis, we need to practice, right? We're going to rewire our brain during this practice to support the capacity to be more mindful in the present moment. And so we can sort of focus on anything we want in the present moment. And the learning or the rewiring happens every time our mind wanders and we bring it back, right? We're treading a new path. And so the focus on the body at the beginning in the body scan, A, is easier for people than, say, the breath, right? It's a little more interesting. It's a little more dynamic. And B, people are so out of touch with their bodies, right? And maybe it's even more important for people dealing with a physical illness. And we often say that your body's changed through cancer in many ways. Some people have literally surgically had parts of their body removed. There's scarring, there's fatigue, there could be pain. There's all sorts of psychological reactions to the part of the body that was ill. And so it's around, we often use the term refriending, right? Getting to know your body again, thanking it that it's still there. Jon Kabat-Zinn often says, as long as we're here and we're breathing, there's more right with us than wrong with us, right? And so focusing on the beauty and the incredulity of the body and what it can do, right, as we move through. So there's an element of gratitude, but really more just about knowing when the body is tense, knowing when the body is relaxed, being connected. And it's really an embodied practice. I mean, mindfulness is an embodied practice, right? Meaning you have to be in the body to do the practice. And so people are very disembodied. And we use that quote, from James Joyce, Mr. Quinn lived a short distance from his body, right? And many people are like that. And so really, the body scan is twofold. You're helping people get back in touch with their body, and you're using an attention-focused exercise that's fairly easy to have, initial quote-unquote success.
Yeah. So, and just to add to that point, because when we see that people struggle early in the programs, because they have been disembodied most of their lives. The reason why we are highly variable on this, most likely, we've had different experiences in our bodies, and also that we've evolved from a place where looking to the external world to give us the rewards we want somewhat is in conflict with trying to look internally, because there's nothing truthfully to be gained in that moment, right? We're trying to reduce arousal states enough to be present without yearning for something. But that's why it's so hard for people, because we are literally wired to be looking, yearning, and grasping, right? And so we try to address all of those things, and that's one of the fundamental practices.
Yeah, I mean, and that's where the attitudes are so important, right? And again, the core attitudes we get from Jon Kabat-Zinn, and there's many kind of more that have been piled on, but non-judgmental. And again, we don't start with non-judgmental. We just start with awareness of judgment. Just noticing that you're actually doing this, you're evaluating your experience and liking it or disliking it or wishing it was different, right? As well as things like patience, acceptance, non-striving, right? Non-attachment. These are all things that are completely antithetical to the way we're trained to live our lives in Western culture. So I would say that for our cancer patients, the two biggest ones are acceptance and letting go, right? Because no one wants to have cancer. And so often they confuse acceptance with kind of giving up or giving in, right? But whereas acceptance is just seeing clearly where one is and, accepting the reality of the situation. It doesn't have to be good. Like, it sucks, right? In many cases, it feels rotten and no one wants to be there. But if you're there, you're there, right? And so accepting our circumstances and our experience is so crucial for any genuine attempt to move forward, for one thing. And so we work a lot with acceptance. And again, making the distinction. It doesn't mean you're not going to do anything, to try and improve your outcomes. It just means you're going to see more clearly where you're at and again, apply self-compassion. So acceptance goes with self-compassion hand in hand.
Yeah, and people may wonder, like, oh, how do you just become radically acceptant? Does it all of a sudden happen? But it goes back to those practices that you were talking about. Because if you're practicing moment by moment to see the arising of discomfort, acknowledge that it is there. We're not trying to push it away or anything, but acknowledge it is present, and to accept that it is just part of the phenomenon of being human in that moment. And then you see that it does pass also. You do that over and over, like you said, which is, probably the phase 2 of this practice. Phase 1 was getting the attention to do that. Perhaps it leads to longer term gains in what you're saying. Like, you can handle the bigger issues and see them in a familiar way. That's
right. And gaining the insight through seeing clearly that if we don't accept something, we suffer. Like, seeing and experiencing that process in real time as it's happening is a real eye-opener for people. Okay, what if, there's a pain in the knee. I hate this pain. I wish it would go away. It's going to be here forever. Now you're escalating your suffering. Okay, I see pain in my knee. Well, let's just breathe into it. Maybe I can release the muscles around it. It's probably going to pass, so you're more in the moment. You're thinking about it differently, and it's not leading to as much suffering. And that's the whole point is, don't listen to me. I'm not going to tell you about it. I want you to experiment and see what actually happens in real time when you do these things, when you don't accept something, when you have aversion and resistance versus acceptance. Like, what actually is your experience?
Very good. And the yoga part. So we've opened with the body scan, some of the fundamental mechanisms that go into what's happening with attention and non-judgment and acceptance. And then why bring in yoga at all? And what do you see that helping people with?
Well, I think it's an extension of that idea of reconnecting with the body, right? And noticing, you're bringing in the element of movement now in breath. So when we do yoga, it's all about the breath, and moving the breath as you move the body, and just really tuning in to what it feels like to raise your arm up in the air very slowly as you inhale. Where do you feel it in the body? What's the type of sensation? Again, because people have often been disconnected and they haven't refamiliarized themselves with their body as it is post-cancer or during cancer treatment, right? So again, it's a very kind and gentle way to begin, and a safe way to begin moving again and reconnecting with the body. And we don't emphasize the fact that you're going to get stronger or more flexible or anything like that. But people actually do. And they find that that's really motivating to them. It's like, wow, I can actually do this movement, whereas two months ago I couldn't. And so another way we think about it and present it to people is that we're going to teach you a whole smorgasbord of different mindfulness practices, of different ways to bring mindfulness to your life, right? And by the end of this program, we'd like you to have, picked your favorite items and walked away with your plate, right? So some people love the yoga. They're just like, it feels so good in my body and I'm in the moment and I'm going to keep doing this forever. And other people are like, yoga, no, not really, but I love the body scan, right? Or I love the minis. We do these mini breathing exercises. And so they take away from it what seems to resonate with them. And I think that's great.
And I think what's commonly done is the dialectical part between teacher and students. And so that's another element. And how do you see that working with people? What do you think is the function there?
Yeah, so that sort of process of inquiry, the way I like to do it is, again, keep people in the moment, keep people in the body, right? So when they'll say, I had trouble with the body scan, well, what happened? What was your experience? What did it feel like? And that's a very good way to just sort of problem solve around, what actually is happening when they do their practice. But I really like to draw in all the other participants, right? So, someone might say, I woke up in the middle of the night and my mind was racing and I couldn't get back to sleep. So I tried to do this or that. So of course I have a whole bunch of answers, but I check with everyone else, right? Oh, did that happen to anyone else? How did you deal with it? What was your experience of it? And you get much better ideas and responses from the other people in the group because they're actually going through this right now, so they'll share their experience. And so that sort of back and forth, exploration and sharing is really, I think, one of the most valuable parts of the program. And again, you brought up the question earlier, well, how do we know what's beneficial? Is it the group support? Is it the mindfulness practices? Is it the yoga? That's, again, an empirical question, right? There's been researchers trying to sort that out, by disentangling parts and only doing the meditation maybe individually versus, all the other components. And we still don't know the answer to that question, but I think each part can be beneficial in and of themselves. And when you bring them together, we know we have a very powerful package.
Yeah, and their integration would be an excellent form of teaching. We would do it in any scenario, right? So let's take the case of physical exercise. You have to watch someone else do it correctly. You have to practice it yourself and then get coaching about alterations in your practice and also hearing others' alterations. We can socially learn without having to do that behavior ourselves. So It's just an excellence of education here that's using a toolkit of various ways of getting to that. So I don't think it's anything strange. It's what we do when learners are trying to gain a new skill. So in transition, thank you so much with talking about the clinical elements and what we see in our groups, and maybe we'll transition here to your clinical trials work, because you also have your research hat. You've done great trials. I've enjoyed your work. I've used it to substantiate some of my own work when I've tried to do some of these brief interventions, even when people are actively receiving chemotherapy in the clinical chair. So you've motivated me in a lot of ways to explore this. And I want to give you a chance, do you want to talk about what you think, how you see your work maybe broadly, and then what were the most important findings garnered from what you were doing?
Sure. Yeah, I think, go back right to the beginning. We conducted the first clinical trial of a mindfulness-based intervention for cancer patients. That very first study we did in 1998, and it was published in 2000. So that was, in a way, a landmark study because it was the first one that had been done in the area. And there we just took anybody who was interested in this new program. We evaluated them pre and post. We focused on stress and mood symptoms. And then we followed them up for 6 months, and we had a waitlist group as a comparison. And really found, surprising even to us, large effects on things like anxiety, anger, sadness, vigor. I'm trying to think what else we measured there. We looked at a range of different symptoms of stress, and so really saw large effects that were maintained over 6 months in our participants. And so that really made us think, maybe we're onto something here. this could be the start of something interesting. And so that's actually when I got my first a postdoc to study it, and then continued with an academic appointment. And so really it was a very new area. No one had really looked at mindfulness in cancer patients. So we just sort of went exploring in different areas that were issues for patients that we worked with. So we looked at sleep to see if it could help there. We looked at things like pain and fatigue as well. And then with my background in psychoneuroendocrinology, we started taking blood samples and saliva samples and looking at things like stress hormones, what was happening with cells of the immune system that were related to inflammation, different types of hormones we looked at, a range of different things over the years, and then just started doing more sophisticated studies, right? So I was interested in that question of comparing the mindfulness program. Once we knew it was helpful, we were pretty clear on that. It was helping people across a wide range of things. Then the question was, well, how is it different from anything else, right, that I talked about earlier? So we compared it to a supportive expressive group, so just a standard talk therapy support group. We did studies of that sort and actually found the mindfulness had more benefits in general, although the other group also had benefits. We expanded our biomarkers, so we started looking at telomere length, which is a measure of cell aging, and shorter telomeres are associated with risk for a number of different diseases, including several types of cancer, and actually showed for the first time that a short-term mindfulness program could have some effect on telomere length with less shortening. And then we also compared it to cognitive behavior therapy for insomnia because I was interested in that. And then I guess the next big jump was starting to adapt it for broader implementation. So we developed an online version, and this was in 2011 or 2012. So we developed like a Zoom version of the mindfulness intervention. So it was real-time video conferencing. And so we tested that out in rural participants who couldn't come in person. So we did that in 2012. And then more recently, we have developed an app-based version of the program that we've been testing across Canada as well. And now we're doing a virtual reality guided meditation pilot as well. So been interested in sort of different ways that we can make it more accessible for people.
Great. And so to bridge what you said, it appears that if you compare a formal mindfulness program to a support group, which was one of our core questions and problems to resolve, there's additional benefit. Was it mindfulness plus the support group, or the mindfulness program acted as it was kind of its own support group, and we're just comparing support group types? So
it was a comparative effectiveness trial, meaning you take whatever exists in the real world and compare it to something else that exists in the real world. Mm-hmm. So we took the MBCR program, the mindfulness-based cancer recovery as is, which includes the social support and everything we talked about, and the supportive expressive therapy, which was a real thing in and of itself that had empirical evidence that it benefited breast cancer survivors in this case. And we just compared them head on. So we did find benefits of the support group, but there were additional benefits of the mindfulness group on top of that.
Additional benefits to be gained on top of the support group. And that CBT comparison, where we're really focusing on was it individualized cognitive behavioral therapy or group-based?
It was group-based CBTI. And this was for cancer survivors who had a clinical insomnia. So they had an actual diagnosis of insomnia. Yeah.
And was there equal improvement, or did it again show some?
Actually, and that was a very interesting study, and I could get into the methodology of it. But people were blinded. They didn't know what intervention they were going to get. They just had insomnia and they wanted a behavioral intervention. And so more people tended to drop out of the mindfulness group because they were like, why am I learning to meditate? I just want to sleep, right? But the people who stuck it out, we found that the CBTI was better specifically for insomnia in the short term. But over the longer term, 3 months post, the mindfulness was equally as effective, but not more. So if you have insomnia, do CBTI and then do mindfulness.
And these trials are always so hard to do. And I guess the impressiveness is that you're targeting something completely indirectly. So you lost, like you said, a motivational element. That people say, hey, I want to sleep better. And if you're giving them something direct about sleep, they will assume that they're going to start sleeping better. So that's another thing with that study that made it even harder was that there was a huge chunk of people who were eligible, except they had already taken mindfulness. They'd already taken our program.
So that basically eliminated everybody who had a vague interest in mindfulness to begin with. So we're left assigning people to the mindfulness group who never would have done it on their own volition. Right?
Important motivational elements there.
Yeah.
And then so you mentioned the stress and immune function. So I've done some of this work too, and that was pulling from some of your work and others. I had a similar training background and did a postdoc in psychoneuroimmunology under Michael Irwin at UCLA, and done some studies on sleep. But it really is, these are important questions because it shows the evolution of a field. You start typically like early on subjective reports or people saying it's better, that's feasible. People report that they like it and symptoms are being reduced. And then we head towards like, how can we make this clinically relevant and based on objective assessment? And why are measures like salivary cortisol, blood levels of immune activity, and other parameters, why do you view these as so important in the evolution of the field?
Well, you might find this a bit controversial, but I actually don't think they're that important myself.
No,
I really don't.
I just want your opinion. Yeah, I don't mind.
No, and I'll explain that. What's important to me is how people feel and how they're functioning. And if they tell me they feel better, that's important to me. But there is a huge role that the more hard outcomes play in how the rest of the world views the intervention. Right. So I was not at all surprised. I know that, psychological interventions get into the body. And so showing that, for example, our stress hormones become normalized or healthier, inflammation goes down, we can affect the cells of the DNA. Like that's really cool. And it's not surprising to me, but the impact that has on the field as a whole is huge. Like that telomere study that we did was picked up by 350 media outlets. Was all over the place saying, oh my God, mindfulness can actually affect your health. I'm like, duh, but that's what it takes to sort of get people on board and, convince them this is something real that they might actually want to try, whereas I'm much more excited about the quality of life findings, but, that's kind of boring to a lot of more the hard scientists or the lay public. So yeah, the nuance of how it gets into the body and, what kinds of, like, for example, in our current study with Tai Chi versus mindfulness, we've added in gene expression. Like that's super interesting, right? So how does something you're doing, a mind-body practice get into the level of the gene expression? It's interesting, but I don't think it's as important in terms of the patient experience, as those other kind of outcomes.
Yeah, I think you're right on. The patient experience, they want to feel better. The research world wants to know if there's fundamental changes that are happening outside of the patient experience. And that's okay. Those things can go hand in hand.
Yeah, absolutely. We need them both, right?
Yeah. And sometimes when it's relevant, the way I was thinking about it, and hopefully I can do a longer term study on this, is, we note like blunting effects on certain physiological parameters. Like you can take cortisol and saliva, and if you see this blunting during the day, we know that can predict like mortality, morbidity outcomes. So if you use that as an outcome, you're like, hey, we're shifting that. Then patients can also say, well, does this increase my longevity? And
that's a question I always get asked, right? Is do you think these practices can help people survive better or longer? And that's kind of part of the answer is that it's a very difficult question to address scientifically. So for me to actually answer that question, I would need millions and millions of dollars and hundreds of patients. And honestly, it's not of that level of interest to me to answer that question, right? So we don't know.
And so any final topics? You mentioned that you're heading to this online world, which so many of us are in. Are there any overall topics after our discussion that we missed or you want to point out that are super relevant to you right now?
Well, what's really relevant to me right now is dissemination. So scalability is getting it out to everybody, is making it accessible. Right. So, we've developed these programs. They're largely inaccessible. I wrote a commentary a few years back called Wealthy White Western Women. Mindfulness-based interventions are not accessible that's the main group of all our research and our consumers. So how can we make these things appealing, accessible, approachable, and also effective for other types of people? So that actually is one of my main motivations for doing the app-based research and doing more patient-oriented research and actually trying to address some of those issues around equity, diversity.
Great. And that's a good place to end. And where can people find you online if they wanted to follow your work?
LindaCarlson.ca is my website. I like to post stuff on Twitter, so I'm at Linda_E_Carlson on Twitter. And I'm all over the other platforms too.
Thank you so much, Linda. Wonderful conversation with you today. Our listeners can find our recordings here today and others and the full menu of our services at goamra.org. That's GOAMRA.org. You also are welcome to become an association member or subscribe to our monthly bulletin. Thank you.